All right, so we've talked a little bit about inflammation and infection, and so now we're going to go a little bit more into the immune system itself. Here are your objectives, straight from the textbook. We're going to get into how the immune system works, and then we're going to touch a little bit on HIV, which will be kind of a precursor into our last lecture of this unit, which will be on sexually transmitted diseases. Okay, so our immunity is our ability to resist disease. An antigen is basically any substance in the body that elicits an immune response. So all of the body's cells have antigens, which help the body essentially recognize itself. And it has, three functions of the immune system. Sorry, I'm trying to prevent a sneeze. Oh, so there's three functions to the immune system or the immune response. The first is defense. So we're trying to protect ourselves against microorganisms or infections. Any sort of foreign anything is what we're trying to defend against. Homeostasis, which is, we kind of talked about this in fluid and electrolytes. It's basically trying to maintain that balance within the body. So we want to get rid of any sort of damaged cells or substances like proteins, lipids, nucleic acid. Our immune system is really good at getting rid of any of our stuff that's not working, so that the stuff that is working isn't, fighting for energy or fighting for resources from the broken stuff. And then surveillance, which is even more onto this. It's basically searching for mutations within our DNA or any sort of mutations within the cells. The body recognizes those as foreign cells and destroys them. So it's a good way to kind of stay on top of our cancer game a bit. We have innate and acquired immunity. Innate immunity is basically what we're born with. It's what babies come out with. It's a first line of defense. It's very not specific, and it's not very effective either. And then we gain this acquired immunity. We acquire it over our lifetimes. And we develop it in two ways, either actively or passively. So an active acquired immunity is something if we've had contact with an antigen, whether we've been infected by said antigen or if we've been immunized against it, so vaccines, and then our body develops the antibodies. So I always think active immunity, your body is actively developing those antibodies to the antigens. Passive immunity is we basically are just given the antibodies. So whether that's an infant receives antibodies through mom's breast milk, or we can also give injections of antibodies. So this would be like immune globulin is something that we'll give. We'll give antibody injections for hepatitis B or for rabies if a patient's been exposed. Or like monoclonal antibodies was a treatment that we were using during COVID. Again, it's just our body isn't making those antibodies, we're just being given them. Okay, so the lymphatic system. We have central and peripheral lymphoid organs. So the central lymphoids is your thymus gland and your bone marrow. So our lymphocytes are made in the bone marrow. And then T lymphocytes are differentiated in the thymus gland. And the next slide will kind of get into the difference between, B lymphocytes, T lymphocytes, all of those. Your thymus gland is largest during childhood, and then it shrinks after puberty. And so by the age of 75, we're no longer producing many T cells. And so this is why some of our older patients can have a lowered immune system. Lymphoid tissue, so our peripheral lymphoid organs, like our lymph nodes, tonsils, spleen, like the spleen filters foreign antigens in the blood. And then the lymphoid tissue is kind of in areas where we would be exposed to antigens, right? So our gut, we'd be exposed, to pathogens by eating it or ingesting it. Genitals, sexually transmitted diseases are transmitted through there, or just like urinary tract infections, that sort of thing. bronchial, so if we breathe it in, this is where you're getting your pneumonia or your influenza-like viruses. And then skin. So our lymphoid tissue has it has specific areas within those tissues that protect the body from those external microorganisms. Okay, so here's where we kind of get a little bit into the lymphocytes. So remember we talked about monocytes that became macrophages. They become like the really big Pac-Men to eat things. They actually capture, process, and present antigens to our lymphocytes. And then our lymphocytes are made in the bone marrow, and then they differentiate into B and T lymphocytes. B lymphocytes make the antibodies, whereas T lymphocytes, they last usually a few months. They can last a few months or up to a person's lifetime. They are what contribute to our long-term immunity. And so you know how sometimes you get a cold every year? It's like that's the few months, right? You develop some T lymphocytes to that specific virus for just a few months, and then you can get infected with it again next year. Same with influenza. It could be a different strain or it could be the same strain. Or there's some viruses where you're exposed to that and then you have that long-term immunity from those T lymphocytes. You also have natural killer cells, which are part of your lymphocytes. T cytotoxic cells attack antigens to help destroy the pathogen, whereas T helper cells stimulate phagocytosis and that B cell proliferation of the antibodies. The natural killer cells aren't B or T cells. They kind of do that surveillance that we talked about before. So they're checking for those malignant changes, trying to get rid of any sort of mutations or cancers trying to develop in the body. And then T dendritic cells are kind of what I was talking about with the lymphoid tissue. So they actually have like little dendritic processes that extend their reach to capture antigens at the site of external contact. So like on our skin, our mucous membranes is where those T dendritic cells are. Again, this is kind of getting into the weeds a little bit. So I don't really want you guys focusing on like memorizing what each of these do, but it is kind of a cool process to see. And I mean, if I move my face and kind of what we were talking about, it's just basically an image of what I was saying. So these macrophages they're eating the virus and then they're processing those antigens to present them to the T helper cells. And the T helper cells are like, oh, okay, I get that antigen. And then they go to the B cells, and the B cells are like, I'm going to make this antibody for that specific antigen. And so now your body has that that long-term immunity against that specific antigen. Again, don't try and memorize this slide. You're going to get lost. Cytokines. So cytokines are secreted by your white blood cells. They alter cell activity, so they can increase proliferation, secretion, that sort of thing. They act as these little messengers. And again, there's over 100 different kinds of cytokines. The two most common are interferons and interleukins. Interferons are antiviral. They promote the immune response. Interleukins also promote the immune response. I know you've heard the term cytokine storm before. I know it was floating around during COVID. Basically, during a cytokine storm, you have these various inflammatory cytokines and they're produced at a much higher rate than normal. And so this overproduction causes a positive feedback loop on other immune cells, and it allows immune cells to be recruited to the site of injury. And if there is no site of injury, then it's like leading to organ damage. It's basically like you have way too much of an immune response and it's hurting your body. So there's two different kinds of immunity. There's humoral and cell-mediated. So humoral is your fast response. These are your antibody immunity produced by your B cells. And then you have cell-mediated immunity, which again It's a specific antigen that's recognized by your T cells, and this is also what's surveilling for malignant cell changes. There's 5 different types of immune globulins or antibodies. It's the same thing. So immune globulin, antibody, like same term. I talked about how we can give immune globulin injections for hepatitis B exposure or rabies exposure. We give those immune globulin injections first, and then we follow it with the vaccine, because the vaccine takes a little bit of time for your body to build up those antibodies on its own. I don't want you memorizing these 5 different kinds of immune globulins. I mean, if you're interested, you can definitely go into your book and read more on it. Some of them are bigger, some of them are smaller, so some show up and they're confined to the intravascular space. Others can move intravascular to extravascular. IgA is what infants get from breast milk from their moms. Again, don't really need to memorize these too much. I would be familiar with the difference between humoral immunity and cell-mediated immunity, though. It's like I have to constantly move my face around. I hope you guys don't mind. So special considerations. These are kind of like some of our other populations that we're looking into. So we have immunosenescence, which basically it's like senile immune system, right? So it's decline in the immune response with age. So it's a gerontologic consideration for our patients. So the big thing that we're thinking of with what we've just learned about the immune system, right? So our thymus gland disappears by the age of 75 to where it's not producing many T cells. You have a higher incidence of cancer because your body's just not surveilling very well, because those T cells are responsible for screening for cancer. I know it says you have a lower antibody response to immunizations, but antibody function isn't as impacted as like the T cell function is. But patients, our elderly patients are more susceptible to infections. Immunocompetence, that's easy, right? It's a competent immune system. Table 14.7 outlines some good examples of hypersensitivity reactions. Do not memorize the 4 types of hypersensitivity reactions, right? So you have your competent immune system, and then you can have an underreactive immune system or an overreactive immune system. Underreactive would be like immunodeficiency diseases like HIV, cancer. If you have an infection, that can impact your immune system so that it is not, if it's already fighting off one thing, it's going to have a hard time fighting off another thing in addition. So those would be examples of underreactive immune systems. Overreactive immune systems are like your hypersensitivity disorders or your allergies, and then autoimmune diseases, which is when the body's own immune system doesn't recognize those self-antigens and starts attacking itself. Like I said, table 14.7 outlines the 4 types of hypersensitivity disorders, but I wouldn't go into memorizing it. It's just more kind of just glance over it. I would know table 14.9 for common allergens that can cause anaphylactic shock. And then just know that hypersensitive people can be more at risk for those anaphylactic reactions. So if they have an allergy to something else, they're more likely to have an allergy to additional things. And that is something as nurses we need to be aware of and monitor our patients for. All right, chronic allergies. So this is one of the most common chronic diseases in the world. They develop from your body producing antibodies to a substance. So what just depends on what substance you're allergic to, right? So whether it is, grass pollen, weed pollen, flower pollen, dog fur, cat fur, or is it saliva? But those sorts of things, right? Your chronic allergies that you can be allergic to. To identify chronic allergies, we actually do a skin test. So skin tests can be 3 different things. They can do scratch tests. So they scratch the skin, kind of do a little abrasion, and then it's exposed to the allergen. And then they look for how swollen the skin gets. Same with intradermal injection. They're injecting the skin and they're watching for a develop of a welt and how red the skin gets or spreads, or they can patch test it and just like put a patch of the substance on the skin. The big thing is because we are testing the skin and we're testing for an allergic reaction, our patients can't take any sort of antihistamines or steroids beforehand. And that's because we want the patients to have an allergic reaction. We want to see how much their skin reacts to these allergens. And then steroids, actually, they're anti-inflammatories. So again, we want the patients having an inflammatory response if they are allergic. The other thing that we're watching for with these patients is anaphylactic reactions, because if we're exposing them to allergens, right, if we're scratching their skin, if we're injecting their skin, they can have an anaphylactic reaction. And so we monitor these patients really closely for at least 20 to 30 minutes after they've been exposed to the allergen, because that's usually when an anaphylactic reaction is going to start. And it develops quickly, right? So symptoms that we want to watch out for anaphylaxis would be like sneezing is usually a first symptom that they'll have, and it's not very troubling, but that's usually indicative that something in the airway is going to go wrong. So difficulty breathing, if the patient starts feeling anxious at all, then we really want to keep an eye on that airway. We have epinephrine on hand to give these patients. That is the medication that we will give to counteract the anaphylactic reaction. Epinephrine is basically like liquid adrenaline, and so it gives you kind of that fight or flight response and helps open up the airways. The big thing about epinephrine and our EpiPens is it's always given intramuscularly or subcutaneously. You never give epinephrine intravenously. The only time you give epinephrine intravenously is if your patient is already dead and they're coding, and they give epinephrine to kind of help vasoconstrict and help start the heart again. But if you give epinephrine IV to a patient that is alive, you can kill them. So never give intravenous, like IV push epinephrine for an allergic reaction. It's always sub-Q or intramuscular. And then the other thing is this angioedema. If you've heard that term before, it's basically swelling of the tongue, the mouth, the lips, which is an indication of that anaphylaxis, and the patient could lose their airway. When it comes to chronic allergies, we want to reduce our patients' exposure to the allergens as much as possible. So environmental control is kind of like how some patients, if they find out they're allergic to cats, they have to give up their cats, or they're not going to go visit family members who own cats, or the family member will try and keep the cat in a separate room while that person is visiting, that sort of thing. It could be that if you are severely allergic to bees, you're not going to be working at an apiary, right? You're not going to be dealing with those bees. The other thing is that many allergic reactions are worsened by stress. So we want to teach our patients to help them reduce their stress levels. There can be treatments for chronic allergies. There's many over-the-counter medications that are recommended. Antihistamines, decongestants, they can use steroid or antipruritic creams, so anti-itch creams. Another one that's coming out is immunotherapy. This is one that if you know somebody who has chronic allergies, you've probably heard of it. So these are, we'll get into it here in our next slide. Move the face. So immunotherapy is generally, it's a desensitization process. So you're actually given a small dose of the allergen to desensitize the patient to their response. And so it's these like little increasing doses over time. Again, because we are exposing them to the antigen, these patients, the allergen, these patients need to have an EpiPen on hand, or we need to monitor them for 20 to 30 minutes after they've been given their dose. These are generally for allergens that can't be avoided or don't respond very well to other medications. It's not a recommended treatment for food allergies as of yet, but I believe more is coming down the way with that. Like, I think they are starting to develop some good treatments for it. It is a very strict schedule. So they're either coming in once a week or twice a week for these injections. And it can take 1 to 2 years to achieve maximum therapeutic effect. If a patient misses a dose, then we need to contact the doctor because, again, it's this very structured, scheduled little ups in doses. And if they miss a week, they might even need to go back a step or get the same dose that they had gotten the week before. Either way, we need to contact the doc to figure out what dose that they're going to get, if any. And then, like I said, we're watching for anaphylaxis. Patients who are on these treatments generally have EpiPens at home. And then sub-Q injections are the most common, but there's also some that are sublingual. So the patient can put like a dropper underneath their tongue of whatever allergen they have to be exposed to. We need to talk about latex allergies. We are working in healthcare here. And so you need to be very aware of this for yourself as well. This is something that I have developed over my years in healthcare. And so I no longer use latex gloves when I am if I'm doing a sterile procedure, I have to go get non-latex gloves. Most of healthcare is moving away from as much latex as possible because we know this repeated exposure to latex generally develops an allergy. So we increase our exposure, we increase our risk, and that risk increases with repeated exposure. So there's 2 types. There's the type 4. Don't get confused by it being type 4 and type 1. There's just the 2 main types of latex allergies. Type 4 is a contact dermatitis. This is a delayed reaction. It happens about 6 to 48 hours after being exposed to latex. And you get dryness, itchiness, and redness of the skin. This is where I'm at. I'm at a type 4 contact dermatitis. And I just haven't played with latex since because I don't want to develop type 1. So type 1 is that like anaphylactic allergic reaction. It's instant. You get hives, asthma, that anaphylactic reaction. It's hard to breathe. Latex food syndrome refers to the fact that many patients with food allergies can also have a latex allergy. So some of those common foods are like banana, avocado, tomatoes. Most people with a latex allergy have at least one related food allergy. And then multiple chemical sensitivity, it's a controversial topic, actually. It's not recognized as an official diagnosis by the AMA, or American Medical Association. It's basically patients who report that they're sensitive to, smells, smoke, that sort of thing. And they get nonspecific symptoms like headaches, fatigue, dizziness, nausea. This is definitely more common in women than men. And I think it's something where it could be an official diagnosis, like, because they say treatment is psychotherapy, which to me is like telling girls like, oh, you're crazy for being nauseous for smelling something, when it's very common for people to have these reactions and these sensitivities. And I think the more that our science is getting better, the more we're realizing like, oh, hey, there's some unhealthy chemicals that we're exposing people to in this. But basically, for multiple chemical sensitivity, you just avoid your triggers. All right, autoimmunity. So this, like I had talked about before, is when your immune system starts attacking itself. It tends to cluster. So usually a person can have more than one autoimmune disorder, or there's like a familial trend, like there's more than one autoimmune disorder within the family. There's an unknown cause to basically any of the autoimmune disorders. We know there's a genetic component, especially since there's familial trends, but it tends to be triggered by some sort of stressor in the patient's life, whether that's exposure to a virus, exposure to stress. Like there's a bunch of different triggers that can bring this on. There are some treatments we can do, which is plasmapheresis. So apheresis is a medical term where it's a procedure that separates out blood components and removes one or more of the components. So like Platelet pheresis removes the platelets. We use this to remove platelets from a healthy person so that we can have like platelet infusions to give to somebody who needs them. Leukocytopheresis removes white blood cells from leukemia patients who might have extremely high white blood cell counts. Plasmapheresis is when we're removing some of those plasma components thought to cause disease. So the autoantibodies, the ones that are attacking our self-antigens, that's what we're trying to remove. The big thing that we want to watch out for with plasmapheresis is because basically it's pulling off a large volume of blood, filtering it through something, and then giving it back to the patient. So it can cause hypotension from those volume changes when it pulls out that large volume of blood. The other thing it can do is it can cause hypocalcemia because citrate is in the little filter, so that the blood doesn't coagulate on the way back into the body. So we're not like taking the blood out and then it clots and we're giving clotted blood back. When we take the blood out, it's mixed with citrate to prevent it from clotting so that it can eventually go back into the body. But citrate loves calcium, and so it can pull all the calcium out of the blood so the patients can get hypocalcemic with plasmapheresis. So like we talked about in fluids and electrolytes, we're watching for those signs and symptoms of hypocalcemia with these patients, as well as hypotension. Move my face. Okay. Immunodeficiency disorders. This is when you have a deficient immune system. So your immune system's not doing a good job protecting the body. Table 14.16 in your book gives examples of certain diseases that can cause immunodeficiency or risk factors. But again, you don't need to memorize this. Stress is a huge one. Malnutrition, lack of sleep. They're really seeing a huge connection between sleep and the immune system. And then like splenectomy or tonsillectomy, removing some of those organs that we talked about early in the presentation that are involved in the immune system. Generally, in immunodeficiency disorders, there's impaired function of something, whether it's the phagocytosis, that humoral response, cell-mediated response, the complement system, or a combination of any or all of these. The big immunodeficiency disorder that we're going to be exposed to in healthcare is HIV, or human immunodeficiency virus. What's great about HIV, if any of you guys are around my age, like this was a pandemic. People were terrified of this in like the 80s and 90s even. But effective treatment has really caused this huge drop in the death rate. What we are seeing, or what we do know about it, is there's sexual transmission. That's the most common. Otherwise, there can be blood exposure from sharing needles or needle sticks for healthcare workers. There's also perinatal exposure, so an HIV positive mom giving birth to a baby. But that is really if they're untreated. So treatment is so effective that I don't think we've had an HIV positive baby born to an HIV positive mom who's been treated in a few years now. If they're not on treatment, then it's still only a 25% risk of transmission. So we don't want to like terrify the moms, but we do want to discuss the importance of treatment. Needle stick exposure for healthcare workers, the risk of transmission is actually less than 0.3% without treatment. And then with treatment, it's 0%. But like I said, sexual transmission is the most common way that you can get HIV. Women are more at risk due to longer exposure of secretions and risk of microtears to the vaginal wall. This would also be true for men in gay relationships who are receptive partners of sex, which that could be a shared function, or it could just be one partner in the role who is taking that on. They would be at more increased risk because, again, if they are receiving the penetration, they are receiving the secretions, and they could also have microtears in the rectum anal area. So HIV is a retrovirus, which is a fancy way of saying it replicates backwards, so RNA to DNA. It targets our CD4 cells, which it can actually destroy about 1 billion CD4 cells a day. And then, so we're monitoring our CD4 levels, which we want the patients to have good CD4 levels. And then we're also monitoring viral load levels, which means we're basically monitoring how much virus we can see in the blood. We want to get that viral load level down to undetectable, because if we can get it to undetectable, then generally it's not transmissible. And so to treat HIV, they take ART, antiretroviral therapy. There's a lot of side effects when it comes to ART, and generally the patient's on multiple drugs, because the more drugs they're on, the more effective the treatment is. It increases that efficacy, but it also means that there's usually more side effects too. So what that can lead to is some non-compliance for our patients. So to help our patients out when they're on ART, because they're also on like a very strict schedule of when they need to take this medication, we can definitely help them make a schedule that makes sense for their lives, right? We don't want to doom and gloom and scare these patients. That's never a good patient teaching. Back to the CD4 levels. So we're watching this via their labs. If it gets less than 500, that can start leading to opportunistic infection. So that's when you start talking about HIV, these patients with the immunodeficiency virus, like they can start getting exposed to infections that people with normal immune systems wouldn't be exposed to. But like I said, with ART, we've seen a really big decrease in both transmission, and also we've seen an increase in life expectancy for our patients diagnosed with HIV. It's really great. There's a lot of research coming out. I believe there's like vaccinations being worked on for HIV as well. And then partners of HIV positive patients can actually be on treatment as well. It tends to be less than what the patient's on. It's like a prophylactic treatment to kind of prevent the transmission. But again, these sorts of treatments have really decreased the transmission of HIV. We are going to get more into HIV in fourth semester. So we're not going too deep into HIV this semester. We'll go deeper into it when we get to fourth semester. But sorry, that case study. Sorry, that was Jack. He is ridiculous. So ignore the case study. I'm going to try and cut that out of the presentation. So if I kind of cut out randomly talking, it's because I've cut that section out. We will talk about that case study in class. All right, you guys have a good day. Let me know if you have any questions.